Differential diagnosis of scaly red skin conditions. That's basically what we're going after here. And I'm going to give you a laundry list, and by all means, you could take notes, but there'll be a lot of photos. And I think what I want to impress upon you is how much can actually look like psoriasis. And I break it down into a few categories: eczematous dermatitis, which could be anything spongiotic, atopic, hand dermatitis, something called psoriasiform spongiotic dermatitis, which often very much mimics psoriasis. Then other inflammatory conditions as listed here, very common conditions, many of them. Connective tissue disease, certain types of skin malignancies, and finally, certain types of skin infections. And you can already see here, there's a lot you have to have in your mind when you're presented with a red scaly skin condition. Now, 95% of the time, I would say, a trained dermatology provider can recognize psoriasis without having to perform a skin biopsy. But those 5% cases should be biopsied and sometimes will represent other diagnoses as seen on this list. All right, so quickly we have eczematous dermatitis. And generally speaking, you can tell the difference between atopic dermatitis or allergic contact dermatitis or hand dermatitis from psoriasis. But there can be overlaps and there can be challenges, which means you might institute the wrong therapy. And even if you did a biopsy, you might find psoriasis in some instances has spongiosis, and that would confuse us as well. So a related inflammatory dermatosis might be lichen simplex chronicus, which is essentially chronic scratching of something that's usually pruritic, and that could be an eczematous dermatitis. But you can see how this could be mistaken for psoriasis, as could this plaque. And then there's seborrheic dermatitis, which is probably most commonly mislabeled. A lot of psoriasis is called seborrheic dermatitis, and perhaps vice versa, because there's a lot of overlap in morphology, but you tend to have this facial involvement and a certain type of morphology of erythema and scale that's a little different than psoriasis, as you can see here. But the symmetry of it on the face, the eyebrow involvement, the nasal labial folds points to this diagnosis. And also it can be in the axillary areas as well. It could be on the chest. This could be inverse psoriasis in some instances, but you have to consider seborrheic dermatitis. Lichen planus, generally a more distinct morphology in my opinion. It's to a trained eye, lichen planus should not be mistaken for psoriasis. It has very specific types of color, morphology, scale is a little different, distribution, highly pruritic. This is lichen planus. And this is a very extreme lichen planus on the lower extremities. But you could easily see this could be mistaken as psoriasis in some instances. Pityriasis rosea, again, has its unique morphology. It has what's called the herald patch, which is shown in this slide, the larger patch, annular patches and plaques, usually in a symmetric distribution on the trunk, usually a younger individual, usually post-infectious. Here's pityriasis rosea. And a trickier presentation of pityriasis rosea here on a darker skin-toned individual. Pityriasis rubra pilaris, again, unique morphology, usually a salmon color. Often these patients are somewhat erythrodermic. They have islands of sparing. You see the white islands of sparing. Again, this kind of look is more unique to PRP. Perifollicular erythema. This is very typical PRP. I don't think it'd be easy to mistake this for psoriasis if you saw regions of the body that had this kind of perifollicular salmon color to it, islands of sparing. Pityriasis lichenoides, clearly that looks like psoriasis, and probably would require a biopsy here. This more of this crusted look of pityriasis lichenoides, but still easily mistaken. There's a psoriasiform graft versus host disease. It's a subtype of GVHD. Psoriasiform looks like psoriasis to me. Obviously the patient would have a history that's more consistent with GVHD, so it would be harder to mistake it. You have connective tissue diseases that look like psoriasis. I always think dermatomyositis, which has its unique flavor. The redness, the patches and plaques are unique, less scale, their distribution. These are the gotrons papules seen in dermatomyositis. More along those lines here. There's a different flavor to these red patches and plaques that make you think it's not psoriasis. What tricks me up is sometimes the overlying patches on the elbows and knees. You might easily say, oh, that's psoriasis, look where it's located. But again, these are less scaly, more just of an erythema, a certain quality to them over the years. You just figure out the difference. This too, very typical patch of dermatomyositis, but the distribution makes you think psoriasis. And then SCLE, cutaneous lupus. Again, it's different, but you have to think about it, especially if you get that kind of presentation, where you have more very distinct plaques, but the scale is not quite the same, the annular formations of the plaques. Here's the scale's a little different than you'd see in a psoriasis patient. This is SCLE. And then cutaneous malignancies. The most common one that we invoke is cutaneous T-cell lymphoma, mycosis fungoides. There's a little bit of a ugliness to the patches of MF that make you think this is not psoriasis. A lack of symmetry, as you see here. Just the quality is very different. If you saw this patient, you'd seen a lot of different patients with MF over the years, you would probably think MF first rather than psoriasis. Concept of parapsoriasis, which is an ill-defined diagnosis, but here you just see that it looks like psoriasis. Maybe a little less so here. Something kind of a digitates look. Bowens, discrete plaques, but if you're not thinking about malignancy, you'll miss this. So you would require a biopsy to diagnose Bowens, the discrete plaques that are nummular. Extramammary Paget's. Sometimes in distributions you find psoriasis. If you don't think about it, you won't diagnose it. And that's the key. You have to think about alternative diagnoses, and there's never a problem doing a biopsy. Finally, infections, which could be as simple as tinea corporis in this instance, but any type of tinea. Tinea in the groin or intergluteal could be mislabeled as inverse psoriasis. So you have to make sure you do a KOH or you do a skin biopsy. Here's tinea corporis. Might be hard to mistake that for psoriasis given the quality of these annular plaques, but much more typical for what they call ringworm, as the name has it. Cutaneous candidiasis, this is obviously going to be mistaken for inverse psoriasis sometimes, more of a satellite appearance. The satellite papules around patches is more of a clue of cutaneous candidiasis. Another instance. This, you might think is inverse psoriasis. So these are always cases where you have to get to the heart of what's going on, else you're going to often institute incorrect therapy. This patient would benefit obviously from an antifungal approach. And then syphilis, secondary syphilis. And if you saw this presentation as a dermatologist, you immediately should be testing for syphilis, right? Because of just the location alone. Discrete papules with some scale over the palms and soles. But there are presentations of syphilis that are more widespread on the body, and they actually can look very psoriasiform. And I myself have missed syphilis, thinking it was so traditionally psoriasis early in my career. Luckily I drew an RPR on the patient. It came back the next day and it corrected my diagnosis. But anytime you suspect secondary syphilis, you should draw the labs, even though your diagnosis might be leaning towards psoriasis. And then scabies, obviously a child. Just the distribution might be mistaken, but scabies is a mimicker, especially in its more severe forms, is more the Norwegian scabies variant. Around the ear, again, you might think, oh, that's psoriasis, goes to the ears, it's pre and post-auricular, but it's scabies. Right, so the upshot of this entire talk is there's a large differential diagnosis of red scaly skin conditions that goes beyond psoriasis, and you need to always assume that it might not be psoriasis, and you have to do investigations as to whether it's straight ahead spongiotic. As you know, you might think something is straight ahead spongiotic dermatitis on the scalp, and you give a biologic for psoriasis, you give a second biologic for psoriasis and it doesn't clear, and then you give a medication like a JAK inhibitor and it clears up. And that to me is a spongiotic dermatitis that's mimicking a psoriasis. The other inflammatory conditions, which are common, those are the ones you probably most commonly would see besides the eczematous dermatitis. Then you have rare conditions like connective tissue disease, malignancies, and finally infections. And so with this list, and there's probably a few I missed, so don't get mad at me if I left off your favorite mimicker of psoriasis. But with this list, you kind of got the gist of it, and you'll get psoriasis right 95% of the time. But those 5% cases matter, and if you see enough patients over your career, you'll make mistakes unless you take that particular approach. So I hope this was a good introduction to the symposium, and we can now move forward with our next presentation.